Welcome to the Erdcast. I'm Ashton Erdman.
I'm Sean Erdahl,
And I'm Zachary Heller.
and today we will be discussing the question, is it acceptable for healthcare providers to have financial incentives tied to patient outcomes? What is your guys' stance on that?
Well, I have kind of a half and half stance. My stance is that kickbacks, they could be good if there is like a positive health turnover. So, like if somebody is sick and they go to the physician and within a certain amount of time they are healthy or injured and they become healthy, and like consistently this physician has that same result where within a certain amount of turnover period they have a healthy patient. I would think that'd be a good place where they should get a bonus or an incentive. But recently we know that it's not great if you can like muddy the data. So a lot of hospitals recently during COVID, they reported a lot of non-COVID deaths, and they reported them as COVID deaths, and so they got kickbacks, which it helps the hospital a lot, so they can help with more COVID patients, and they can help aid them and everything. But in reality, it's not good for society because it creates a lot of distrust between the patient's family and the physician.
Yeah, I definitely agree with your stance there. Like you said, I think there's kind of two sides to the argument there. I believe doctors are more likely to put more time and effort into treating their patients effectively when they receive kickbacks and financial incentives. But I also believe there's kind of some unethical principles kind of in play there as well, because I feel like doctors are more likely to put financial incentives first before patient satisfaction and quality. Now, I'm not saying
Right.
all doctors do. I'm just saying I feel like doctors are a little more likely, to do that, given that gain they can obtain from that.
And I agree with both of you guys. As working as a pharmacy tech for 3 years, I do see how the doctor might want to incentivize themselves and send in a medication or a dosing incorrect and then having the pharmacist send it back to them. Knowing the pharmacist for a while, I know that most of the time they're going to do the best for the patient, and they're going to avoid having them send them back to the checkup and stuff like that. So they'll switch the medication to something that's therapeutic equivalence, or if they recognize there's an allergy, and I guys agree with you guys where the doctor might not recognize that there's an allergy, and they'll send over a medication, and they'll have to go back in because there's some medications that are equivalent, and so the doctor will have to send another thing, and if they get incentives for that, I mean it's an error on both sides. But in a normal time, the doctor should get that allergy medication. And I do see that most of the times they do send over a medication that's correct, or if they do, there's an agreement between the pharmacy and the doctor that most of the times they're gonna send over a medication that it has a cross reactivity is what it's called, such as cephalosporin and penicillin, and the pharmacy's job is just to like, we're gonna tell you that there's like a 3% chance that it could cause something. The doctor's on board with this, we're on board with this, and if you notice anything, call the doctor right away. And I see how that, if it does go backwards, there's a slight chance, and the patient is agreeing with this. If they say, I don't wanna do this, I'm gonna go back to the doctor, I'm gonna get something switched, then they can do that.
So pharmacists kind of acts like that last defense if the
Yes.
doctor were to have, prescribe a medication that may not be commonly used by other doctors because they're being incentivized to do so. You may not know the answer to this, you may not have an experience, but like, have you ever witnessed a doctor like prescribing a drug that the pharmacist does not necessarily approve?
Yeah, so being a technician, I'm not paid, I can't do it to actually check the medication. I mean, I can learn how to do it, but at the end, it's the pharmacist that has to do the drug reviews and stuff like that. So I've noticed that there are times that they have caught mistakes, sometimes by purpose. Like, I know a lot of times, sometimes the doctors will do that and the pharmacist will catch them. Sometimes it's just by accident, which is totally fine. The pharmacists are there to check it, and if they don't check it, in the end, we find an agreement with the patient. I think that if the doctor does send something over that's incorrect, that as a team, we're all there to work together and stuff like that, so.
So you'd say most of the time it's just an error and not necessarily, other reasoning behind it, such as, a financial gain.
I think the only time it would be enough financial gain would be if it's an agreement between, and I'm not saying it's the patient's fault, but a lot of the time the patients do have an agreement with the doctor where they'll get a controlled substance, and the doctor, it might not be a real doctor, it might
Right.
someone might just fake something, just to get a controlled substance because they're in withdrawal and they're just addicted to it, and that's the case with some pharmacological drugs that people will get addicted to and it'll change their perspective and mindset and stuff. And sometimes they might have the doctor send it over and they both get a gain out of it sometimes, and sometimes they both get lost because sometimes the pharmacist will check it and they'll be like, I'm not dispensing this, I can't, it's against the law, so.
Cool, okay. It's really nice to hear that, viewpoint from you working in a pharmacy and having that perspective that probably a lot of people don't have when it comes to this question. Now, we talked about the kind of reasons for, why it may be a good thing or why it might not be a good thing, but maybe we should talk a little more, maybe elaborate a little more on as to why. We talked about pharmacists, having that line of defense. We talked about, COVID and that kind of ordeal. But also, I also think when it comes to the other side, not just drugs, but just like, patient outcomes, that I feel like doctors may be more likely to see improvement in their abilities over time if they're constantly incentivized to have better patient outcomes. They may actually focus on the patients. I feel like it may lead to better communication between the doctor and the patient. Maybe the doctors even have more satisfaction if that occurs. I feel like if I was a doctor and I was being incentivized to have better patient outcomes, I'd be more serious about my work.
Right.
And it'd be less about the short-term gain, more about the long-term gain,
Yeah, and I can see that being a very good thing, and that's kind of what I was saying in the very beginning, was that it'd be good if they have a consistent, healthy turnover, but that could also be bad if they just kind of muddy their stats. If they were to put in and say that, oh, I gave them this medicine and they came back and that was their stat, like they just needed somebody to come back and like have a follow-up or whatever like that, then they could just do something to make them come back. Like I think you were saying earlier before we started the podcast, that like you could do a drug that might work a little bit or just not enough or whatever, and then they could come back, so they need to like get more of the medicine.
Yeah, and going off of what you just said, I was just gonna say that the doctors can do some things where the pharmacy we can't do it unless we
Right.
go back to the doctor, and that would be an example like a dispense as written. If the doctor puts it as, I want brand only, and no generics, pharmacy can't dispense generic unless we go back and we get the doctor's approval and they send in a new prescription. Sometimes that means the patient has to go back and get another checkup, and we don't know the reason for that. It could be for the incentives, it could be not, but that's just a point that I had to make here. And then another reason why is if they don't put dispense as written, or it's not we have it in stock, the pharmacy is always gonna try to find the best thing for the patient. And I just wanna highlight that, if they send in a manufacturer that we have and the patient has an allergy to it, it might not be an allergy to the medication itself, it might be an allergy to the fillers the manufacturer puts. And if we recognize that, we're gonna switch it and we're gonna put a note on there that we're gonna put in a different manufacturer every single time. Just so we don't have the allergy again, so we don't have to go back to the doctor and stuff like that if there's a serious reaction with it.
Right.
And most of the time, going against this, sometimes the doctor is going to put in a prescription for like an EpiPen or something like that, where they know that the patient might have a reaction to this, and so they're gonna have something to back it up, such as something to help with anaphylaxis or something like that.
Right, yeah. That kind of leads me into a point I was going to bring up about it's possible that they might just push medication that can be closely related to like symptoms you have, which is something that actually happened to me where I was having trouble eating and I couldn't figure out why. It was just a while before I'd been able to eat. And I went to the hospital and they told me I was depressed. I had no reason to be depressed. I was actually happier than I had ever been because I had gotten out of a bad situation. And they told me, no, you're depressed. Go to the pharmacy, get this medicine. I said, okay, I trust you. You're the doctor. You know, I was, 19. So I just graduated high school just a little bit ago and I had no idea what was going on. And it was bupropion was the medicine. And I had taken it for about a week and it was making me like snap at my coworkers. I was just super angry. I had never been like that ever in my life. And I just started being angrier and angrier. And it actually changed me permanently. Like just that little bit of time on that drug was enough to make me like a little bit more like hostile.
Yeah.
So like there's stuff like that where it's possible that they do the wrong thing just to do it, like just because they can like if that's a newer drug or they're trying to use that. And I know that happened. I think my dad got diagnosed with the same medicine and he had the same reaction, and if they would have put more like work into it, they would have been able to figure that out.
And the pharmacy doesn't recognize this. They have no insight because they're not the one that's actually checking the patient. They're getting the diagnosis on the prescription and they're like, this medication will work. This doesn't interact with any other medications you already have. We're gonna go with it. If you guys have anything, come back to us or go back to the doctor and we're gonna try to figure this out. And that's what the pharmacy's job is.
Yeah, it's pretty sad, In that case, maybe the doctor did have that incentive, you will never know.
Right, exactly. I couldn't know.
Yeah, I mean, if they did though, I don't wanna say I would, because I don't think I would, but not everyone has a good set standard when it comes to morals and ethics. And some people are actually driven by greed, so those people, they're probably more likely to prescribe a drug that may not meet the patient's specific needs, that they may actually gain from, even if it's unnecessary, because they are driven by that greed rather than the actual practice of their career. For me, I want to go into dentistry because I want to help people. I would never want to, be financially swung by someone forcing me to use a certain drug. I think that would just, I don't think I could live with myself doing that, especially if I knew it wasn't right for the patient.
Yeah, and something that just came to my mind was sometimes the doctor will prescribe a medication that is over the counter and they know that the medication's not covered. The pharmacy will call them and say this medication's not covered. Pharmacy's gonna be like, just buy it over the counter, that way you don't have to go back. If you're getting these symptoms, like come to the pharmacy, we're gonna give you, if we don't diagnose you, but we can give you a recommendation, like you feeling this way, we're gonna try to help you feel better before you actually get worse and have to go to the doctor. So it's free, come to the pharmacy, we don't charge you anything, we just wanna help you and we wanna figure out a way to stop what's causing like distress in your life before you have to go to the doctor and have to pay more. And sometimes the doctor will just prescribe things, and obviously if it's covered by the insurance, then good on them, that the patient's having something that they don't have to pay for, but they're still having to get a checkup. But in some cases, the doctor is just gonna send over the medication, knowing that it's not covered. Patient has to go pay for the prescription, and they have to go to the doctor every single time, and the pharmacy wants to try to reduce that.
Yeah. Bills rack up pretty fast, especially when the doctors, if they can't figure it out or they're not putting enough effort into figuring it out, not bringing enough research. I feel like that's kind of like the whole thing. It feels like they're trying to get better turnover sometimes. I've been to Mayo quite a bit, and it always felt like they're trying to get better turnover. My most recent doctor has been the best one. She felt like she was actually like, she cared a little bit. She was, when I first went there, she was pregnant, so I could tell, she's about to have a kid, so she cares at least a little bit.
I guess going back to, kind of leaving the drug kickbacks on standby, just patient outcomes in general. I feel like doctors who put, patient outcomes first and they aren't focused on that short gain. They're actually focused on long-term satisfaction, and being more effective in their practice. I think doctors are more likely to collaborate with the ACO, which is the Accountable Care Organization. This is just like kind of a board of doctors and medical professionals that actively achieve to have, positive patient outcomes, to prescribe a set of drugs that all doctors should be using, not financially incentivized, but kind of a set standard. And the great thing about the ACO is that money being shared between doctors in the organization actually goes towards the Medicare program, which is actually pretty, awesome. People who can't, necessarily can't afford health insurance, or people who are older and don't get those benefits. I think that's great. And then also the ACO, another goal of theirs is to avoid that unnecessary repetition in care. So, short-term, gains, having your patients constantly come back. But you also said earlier that, doctors may be more likely to have their patients come back if they're incentivized to do so. There's kind of like a two-way, two-headed dragon to that argument there.
Yeah.
So that's kind of interesting to think about as well.
Yeah, that's kind of the hard thing. Is like you can't know as a patient. You won't know, and if you're going there for one issue and they, say they direct you to another specialist or something, it could be something so simple that they could have just recommended you, like my case, the psoriasis thing, where they could have just recommended I go try a specific lotion. And that would have been the easiest thing, but they didn't even ask if I tried lotion at all. They just gave me a steroid cream, and then when I came back, they gave me another steroid cream and said, hey, this doesn't work, go see a dermatologist. That's kind of like, it seems like they're trying to keep you there longer than trying to get you the better thing. And this incentive program would make a lot more sense if they had like a better protocol to do more holistic methods, probably. Like, hey, improve your diet, improve your exercise. Like for me, it was moisturize. As simple as that, just moisturize. So like if we did more of that, maybe the incentive program could come around and be a better thing. But like for right now, I would say it's probably not a great thing, because you can just muddy the stats or just keep people coming back or give them the wrong thing and just not put in enough effort. It seems like that would be the case right now, is that when we're focusing so much on turnover and incentives, we're just not putting in the right amount of effort.
It's kind of funny how you mentioned that, these simple recommendations, like having a better diet or just simply moisturizing, those aren't even, prescribed drugs.
No.
Lots of times drugs are just completely unnecessary.
Yep.
But doctors
Two
will
steroid
prescribe them if they feel that, they gain from it sometimes. So that's just kind of ridiculous on its own.
Yep.
Sometimes there's a simple solution, but someone may be more likely to take the longer solution. Maybe that's not actually best for the patient, just because they benefit from it.
Yep.
Yeah, and Sean was talking about Medicare. I wanted to just step back and go to that. I used to help out Medicare because I've pharmacy tech for 3 years. I had to build Medicare and stuff like that. And one thing in particular is Medicare Part D with test supplies and stuff like that. It's a 3-step process between the doctor, the pharmacy, and the Medicare insurance. The pharmacy has to contact the doctor. We have to send them. We need your notes from this last visit, and most times we need it like every 6 months. And the patient gets so upset and so frustrated that they come to us and we're like, we sent them a fax, we called them, we're trying to get a hold of them. Then the patient has to go back to the doctor and be like, hey, have you gotten this yet? Well, we're still waiting. And maybe they're doing that as a way for them to come back and back and back. And the pharmacy can't do much besides try to contact the doctor. And if the doctor isn't doing it, we have to keep doing it. And sometimes it's with the insurance. Sometimes the Medicare just isn't getting back to us, even though we've talked to them. And so, and in other cases, there's things like prior authorizations. The drug's not covered by the insurance. The pharmacy has to contact the doctor. The doctor has to get a hold of the insurance, and then the insurance gets back to us. There could be a step where the doctor's not doing their step because they want the incentives that they're they're not getting our information, they're losing track of it, they're just not contacting the insurance, and it puts a big hold on the pharmacy, the insurance, and on the patient most quickly, so.
So sometimes it's just like negligence on the doctors and they're not.
I mean, I do see a way where they're busy, pharmacy's busy too, insurance is busy, I do see a way that things happen, they lose it, they misplace it, they just haven't got to it, but with that process taking 2 weeks on its own, and then it being prolonged because either the doctor's just not doing it, it puts a lot of strain on the patient, and it's not fun to deal with
Right.
at the pharmacy.
Yeah. Well, and the patient should be put first. It doesn't matter if you're busy,
Yeah.
you know, it's like, that's kinda like the whole point.
And
It's medical.
especially if the patient is running out of it, and we have to be like,
Mhm.
we can't break this box, it's against the law, we can't just give you a little bit, for test strips, we have to have you buy the whole thing. And we try to avoid that, we want them to get the insurance to cover it before they have to pay the full price of it, so, and the doctor can put hold on that, so.
Something I was just thinking about, it was something I've just seen online recently, is that would be good for you to think about as well, is that some people have been going to the dentist, getting diagnosed with cavities, and going to other dentists and finding out that they don't have cavities. That the dentist was just trying to get them there so they could just drill into their mouth and put in fillings, so they could just do that. But they weren't paying enough attention or whatever it was, but I've been seeing a couple things where that people have been basically getting another opinion and finding out that it wasn't the case that they had cavities, because they thought, you know, they've been told they haven't had cavities their whole life, you know, then all of a sudden, oh, they have cavities?
Yeah.
Go to another one, they find out, no, there's no cavities, what was that dentist talking about? So that'd be a good thing for you to
Yeah.
think about too.
Do you know which dental?
No, I couldn't say, like I said, it was stuff I was reading about online, so
Okay.
it was, like, other people were like, you know, chiming in where there's like a discussion and everything,
Yeah.
like, kinda like we're doing now, where they're just kinda chiming in. And they were saying that, yeah, they've gone to multiple practices and found out that they didn't have the cavities that one had told them that they did before.
Yeah.
Yeah,
Yeah.
and I wanna just go off something, with what you guys are talking about, my grandpa was diagnosed with cancer, and I won't go into too much detail, don't wanna go against his privacy and stuff like
Mhm.
that, but, he was at the Mankato clinic and they didn't catch it, they went to, Mayo Clinic, they found out that he had cancer, and it was 2 months they could have found out if they went to Mankato Clinic, and they would've got it right, so it could be negligence, it could be that they're not trained enough, it could be that they just missed it, but my grandparents wanted to sue them, because but
Yeah,
they didn't
no kidding.
they didn't go through with it,
No kidding.
we're not gonna do this, it's hard enough on us, so, if they're doing that for an incentives, that's just heartbreaking.
Yeah, and I think in those situations, I don't know about that cancer situation and with cavities, definitely, you know, that could be incentivized.
Well, it might not even just be incentivized, it might be just turnover based too.
Yeah. But that just goes to show how important a second opinion can be.
Mm-hmm.
Yes.
And it's really nice that we live in Minnesota, so Mayo Clinic, like the best hospital in the world, is only like a couple hours away, so that's just amazing.
That's all my bad opinions came from, like, not the dentist stuff, but like the ones that were personal to me, they came from Mayo and Owatonna. That's
Yeah.
where it all happened, all the, like, diagnosing me with depression that I didn't have and everything like that was Mayo and Owatonna.
Mm-hmm.
So it's one of those things that you go to the best place, or at least you're thinking you're going to the best place, and you might get just, like this case, it was just like a young doctor that they just kinda were just like, alright, give him drugs. You know, that's clearly what happened, because when I brought it up, they gave me a new doctor.
Mm-hmm. Yeah, I mean, even the best hospital in the world, they won't have the best possible staff, unfortunately.
There's gonna be
Yeah.
that error margin, you know?
Yeah, there's always gonna be outliers, and that's
Mhm.
just quite unfortunate. I kinda wanna go back, I know I keep going back to the patient outcome scenario, but I feel like we kind of focus on
No,
drugs.
we gotta keep bouncing around.
I know I said earlier, like as a dentist, I would never wanna fall into that rabbit hole.
That's why I brought that one thing
Yeah.
up, yeah.
Yeah, but that also is because it has to do with the person's health. Their health
Right.
is on the line.
Mhm.
You're taking more from them, even when it comes to their income in
Mhm.
general. Now, this kind of, contradicts that, but I feel like it's not as, detrimental. I used to work for a mosquito control service company. I would spray properties, mostly residential neighborhoods, me and my
That's
buddy.
terrible.
It's actually the best job I've ever had.
Well, that stuff is terrible.
Oh, yeah, no. Probably not the best for you. Me and him, obviously, we wore
Yeah.
respirators,
Yep.
so we were fine. It's really effective, though, I will say that.
Yes.
Um,
I have plenty of points about that.
Yeah. So we sprayed properties all over the Twin Cities. I mean, we go as far south as Jordan, which is only like 45 minutes from here.
Mhm.
So, and also, as far north as Cambridge too sometimes. So we were kind of all over. So I kind of got to see all these different neighborhoods. And I eventually started to figure out that customers in nicer neighborhoods were more likely to tip you for your service. Now, I will admit, for these properties, I feel like I was a little more likely to be more diligent and, spend more time spraying given this possibility.
Right.
Now, it was never a guarantee. In fact, it was very rare. And a lot of times it was the same person or same homeowner, giving us reoccurring tips. But also, on the other hand, nicer properties also usually mean larger properties. So it usually means you kind of have to spend more time anyway on them than smaller properties.
Mhm.
Smaller properties usually have less bushes and less, plants to spray, so it's a little easier to kind of speed run it. With those bigger properties, obviously more square footage and usually more tree line and plants, so you got to spend a little more time. But I figure I just kind of say that because it doesn't directly relate to this conversation, but it kind of has the same kind of, I guess, moral standards when it comes to being incentivized to do certain things.
Right, so you're incentivized because you're thinking you're gonna get a tip from a better place, so you do better on that place, and you do worse on the worst place. So technically, if you think about it, it's the same thing where you're being incentivized to give basically the more costly drug instead of the cheaper drug, where you could just the cheaper place, you're still gonna get money.
Mhm.
All you have to do is be quick and hasty through the job, and you can still do it at the same quality or whatever like that. But you're thinking in this weird, that kind of like back and forth standpoint while you're doing it. You're like, well, I don't need to pay attention to these guys because this one's gonna make me more money.
Mhm.
So it also incentivizes you to treat patients differently if you think about it that way.
Yeah, and another thing about that is those larger properties, those nicer properties, more of the time versus the smaller properties, someone is more likely to be at home. And I think it's because in that situation, usually there's more likely to be one provider for the family.
Mm.
In larger properties, usually maybe a wife staying at home or someone watching over the house. So also someone is usually watching us do the work too. So that was another factor. Whereas those smaller homes, it was more likely that people, both parents are going to be gone or both homeowners were going to be gone working, because I'm not saying that smaller homes mean more people in the household are working, but I just kind of noticed that. So that's another reason why sometimes I tended to take longer on those nicer properties. Now, it wasn't every time, because sometimes I didn't think about it. Sometimes I go to work tired as hell and just kind of was a drone the whole day. But sometimes, I'd think about, that one time that lady tipped us for doing a good job on her property, where in reality, we were just kind of doing what we needed to do.
Right, you have a job to do.
Yeah.
And that brings me to a point I was kind of thinking about during this, was that you have a job to do. Being incentivized what if it's just a certain brand hospital, if it's just Mayo that's incentivized and not like a different hospital that's incentivized. So now you have kind of like you're saying is that better doctors are going to go to one place, worse doctors are going to go to the other place, and this one's going to probably cost more than this one. So you're not gonna get the same level of care. It's basically segregating your level of care if you do it that way.
Yeah, and thinking about the incentives, this just came to mind that some manufacturers aren't making enough money, and I heard that a lot of times they want it for incentives, they're not making enough money, so they're gonna stop making drugs. And this goes down to the pharmacy because, for controlled medications, they need the medications or maintenance medications, and they need to keep on track with it. And if they're not making enough, we have to call the pharmacies, we have to try ordering more, and we do the best we can, but sometimes we can't do it for everyone because we have to like have a lot of people, and so, and I've heard patients come up to me and they're like, manufacturers aren't making enough. They just want it for the money, and that's not good. Like they have a job to do. They should be making the medications, and if they're not getting paid enough, they should find another job.
Mm-hmm.
Yeah, going the drug conversation, like in your situation where these doctors were telling you the things that weren't necessarily right, or prescribing you drugs that weren't necessarily correct. Yeah, definitely happens. Yeah, and I believe you that there was some negligence on their part and possibly, swayed. But there's other drugs out there. I have some friends that I know who have been on antidepressants where some of those drugs, they kind of take you kind of have to try a few different ones before you find the one that's right for you.
Right.
So sometimes in that situation, it's kind of necessary because you don't know what's best for the patient. It's not like their exact genetic makeup or what works best for them. You don't know their family history. So sometimes it just takes a few tests, a few run-throughs with these drugs to find the one that's best for them.
Well, right, and like in my case it's different because it was a doctor acting as a psychologist, basically saying, yeah, you're depressed and you don't get a say in it.
Yeah, and working at the pharmacy, I see this all the time. Not just switching the medication because the medication isn't working, but also ramping them up, putting them in a higher strength. I see sometimes like for like an Effexor, they would have like a 75 and a 150, and they take a total of 225. And the pharmacist has to check that it's not above the max dose, but you can see the ramping up, that people are going up in dosing because, I mean, it could just be society, but it could just be the doctor's incentives too, that they're just increasing the dosage because they know that it's not like the therapeutic index, it's not going to cause too much of a difference, but they're going to make some more money off of it because they're going to be having more medication to dispense. So
I think it'd be pretty cool or not cool, but like good on the pharmacist end if that like they were seeing certain stuff like you see if like it was the same pharmacist that saw me come in twice with a different to get a different steroid cream. They could have like been like, hey, try some lotion. Like I know they can't. I mean, technically it's your doctor's opinion, but they're also seeing
the
you.
pharmacist can
they're
if they do see something that is over the counter or something that they would. Like lidocaine, for example. Lidocaine, there's some medications that are only prescription only. Omeprazole 40. That's pantoprazole. That's only prescription based. You can switch to other proton pump inhibitors. Omeprazole 20. You can take 2 of them over the counter. Pharmacists could say that it's the same thing as 140. Or if the pantoprazole isn't working, pharmacists might have to go back to the doctor to see if they could switch it. But there's other things that are in the same class that do the same thing that might work better and be cheaper. So, yeah.
Yeah.
Going back, it's almost as if I say this every time, but I feel like you kind of cover a lot of the drug side argument just because you have that experience, and obviously you have that personal experience, whereas I don't so much. But when it comes to like patient outcomes, financial incentives may lead doctors to select patients who are more likely to have positive outcomes, a sort of selection bias, versus those with more challenging treatments and care plans. Actually, a study from sorry, I'm pulling it up right now, from the
Jamie, pull it up.
yeah, a study from the AMA Journal of Ethics basically kind of, looked into this, and they found that some doctors, like I said, more likely to select patients with better outcomes. So let's say a patient, has stage 2 cancer versus stage 3. If there's a financial incentive for a better outcome there, irrationally or, logically, as a doctor, you realize it's more likely going to be easier to treat the patient with stage 2 versus stage 3, where it's actually spread to other organs and gone through the lymph system. It's a lot different. It's easier when it's more contained. And I think that's horrible because that patient who probably has stage 3 cancer is in more dire need of care. They need that more.
Yeah.
And if there's an incentive behind that, a lot of doctors in their area, kind of puts them through a series of setbacks. And they may have to go somewhere like the Mayo Clinic, and like you said, who knows if they'll even be treated fairly
Yeah.
there to begin with. So that's just another whole thing. It's just, some doctors just are corrupt.
Well, it leads me to this point where I feel like there should be a lot more information provided to people that are like coming up in the world, because I came in, I have medical issues, I'm a kid that has medical issues, and my parents aren't in a position to tell me what to do. So how the hell am I supposed to know what I'm gonna do? I go to the hospital, I get treated wrong, and that's my only experience.
And that's because you're trusting those who have a degree.
Right,
those
and
with
that's
more education
exactly.
than you. And
Yeah.
if they're using incentives against it, like that's not right.
And I think in this whole conversation, incentives and turnover can be interchanged, like, because if you're incentivizing turnover itself, then I mean there's a deep rooted issue there
Yeah.
where like the whole system's corrupted to the point where, okay, let's get money out of these people instead of let's make sure they're fixed first. We gotta fix people. That's kind of the whole idea.
Yeah.
Yeah, and I have a bunch of sources here when it comes to patient satisfaction outcomes. One study I found from the NCBI, National Library of Medicine, found that there's a positive statistical relationship between financial incentives for patient outcomes and patient satisfaction, doctor-patient communication, and more thoroughness and patience on the doctor's end. That was one study. But I also found two other studies that showed, one of them showed short-term implementation of this practice of, long-term personal or patient outcomes with financial incentives was not shown to improve patient satisfaction. Another one showed mixed results where some patients were experiencing more satisfaction and they were noticing more quality in their treatment, whereas others were not, and sometimes less satisfaction and quality. So this article specifically from JAMAnetwork.com doesn't sound like a trustworthy source. Well, it was a journal article published in 2001. I don't know the authenticity of the source. I just know from this article the conclusion was that more research should be conducted to examine these outcomes, and I agree. I think research should be kind of conducted in a sort of vacuum, where if we actually want to implement this, or people believe this should be implemented as a practice across the United States and other countries too. It's not really our deal there,
Yeah.
but it should be examined, and we should experiment with it if we believe there are to be positive outcomes. They outweigh the negative outcomes. Based on what we've been talking about, I definitely agree with that, and I don't even know if it would be a good thing to do that.
I'd say it's not.
Yeah.
I'd say it'd be a bad idea, because you're basically planting a seed in a physician's mind to focus on doing something in a different way to get more money, which is not really a good idea when you're supposed to be focusing on the patient and not the profit.
What I believe is kickbacks. If they were to do this, no kickbacks for drugs, because that's easily just
Yep, no
you're
kickbacks.
easily able to rig
They
that.
have to be like I was saying in the beginning. It'd be like strictly like sickness to health turnover.
Yeah. No selection on patients. Not like if you select a patient.
Mm-hmm.
I think the same system should be implemented where doctors or patients come through and they treat all these patients. But I believe with outcomes or financial incentives for phenomenal patient satisfaction without a selection bias, without drugs, without receiving drug kickbacks, I believe that could be beneficial.
And it would be, maybe they could have some kind of, I don't know, somebody that does it, or what, like not an HR, but like some kind of part of the organization that monitors this, that can audit this, so they don't have it where like they can't trying to formulate my words here. Audit it so they can't see, so they're not prescribing things that can be easily solved in other means.
Yes.
So it's like if they could be like, oh, just go run,
Mm-hmm.
just go run. if that's all they need to say, but meanwhile they said, let's do this, let's try this, let's run these tests, let's
Yeah.
test your blood, let's do this,
Yeah.
they probably shouldn't get any incentives.
Yeah.
They should probably get reprimanded, if
Yes.
anything.
Yes, there should be no way that doctors can take shortcuts to
Yes.
actually see better outcomes. It should be, the same system where they
Well,
do the
that is
best.
the shortcut.
Yeah.
The shortcut would be saying like the right thing,
Yeah.
which is exercise.
Yeah.
And
Using
going-
drugs as a shortcut doesn't
Yeah,
make
I
sense
guess
because
the
it
long
makes
cut.
it makes the problem longer.
Yeah.
and to go
you're right.
off of that, the doctors can prescribe, like, there's medications that are not controlled and medications that are controlled. Benzodiazepines and other, like,
Mhm.
medications for mood, they can be used in anxiety, they can be used similarly, but the doctor might wanna prescribe, a controlled substance because they only last 6 months at a pharmacy, where anything not controlled is gonna last a year.
Right.
That way the patient has to go back and get another prescription every single 6 months rather than every year.
Right.
And another thing is, and I see this all the time because I work night shifts, so a medication for like an oxycodone, a pain medication, or some kind of controlled substance. There's some other laws with like controlled substances like the C3s to C5s. They can be transferred if it's already been filled out of pharmacy once. But we're just saying, say for example, it's a new prescription. It's nighttime. They send an oxycodone. They send it to the pharmacy that the patient usually goes to, even though the patient comes up to us and like, I told them specifically to send it to your pharmacy, you guys are open. The doctor may wanna send it just to that pharmacy, just so patient might have to go back. Cause we can't, as a law, we can't be like, oh, it's sent to that pharmacy, let's call that pharmacy and have them, we can't transfer cause it's a C2, but we can't be like, we'll just wait till tomorrow for them to cancel it out.
Right.
So we might have to have them wait till the next day to go back to the doctor to get a new prescription sent to us.
Yeah.
And just because the doctor was,
And that might not be good for the patient at all. They
Yeah.
need the medication now.
yeah, and it's heartbreaking, but sometimes if it goes against the law, we can't do it. There's sometimes when there's a way that we are able to have them get the medication because the doctor sends it again to us, and maybe they forgot or something, but sometimes it's just sent there and we can't do anything about it. The pharmacy's closed, the doctor won't answer, and we can't transfer it, so.
I could be wrong here, but that situation specifically, I doubt that the doctor's trying to achieve a better patient outcome, because as the patient, I'd be more annoyed than anything at all
Yeah.
if I had to go back to the doctor and, run back and forth. That would definitely, on my end, less patient satisfaction, so.
Yeah, I've had very little satisfaction with mail. That's kind of how my experiences have gone. It's like, do this. Oh, you live in Owatonna? We're gonna send your prescription to the Waseca Walmart. Like, that makes sense.
Yeah.
And I mean, the timing is both on patient's timing and other things, but like there's some things with insurance too, where like the insurance is gonna have only this specific doctor can send something, and so there's some things with the insurance that go back and affect the doctor too, but sometimes it is just the doctor's negligence or something like that, so.
Yeah, I can't imagine I needed a dermatologist to tell me what I found on Reddit.
Yeah. I mean, it's kind of screwed up if you can figure out a better treatment plan for yourself
Yup.
than the actual doctor.
Yeah, and that seems to be the case sometimes. But I'm speaking for things that are like usually, you can actually manage them if you know what to do
Yeah.
to manage them, or if you get the right advice. But obviously, nobody's gonna be able to go like run off cancer.
Yeah.
That's not when you walk off. That's kind of. This is like a sidestep, but this is also technically a medical professional. I brought my dog to the vet for, I wanted to do a cancer like screening because he had lumps, and the vet literally said, if they grow anymore, then we'll say he's got cancer.
That's awful.
That's awful.
They didn't know more,
Like, it's like, could we like put a biopsy on it or something like that? But no, it's like, so I feel like it's just like across like all medical professionals, there could be improvement, like for like just not focusing on turnover and focusing more on
thoroughness
and focusing more on healthy Patience.
See, that's why I say with the current system,
Yes.
patient incentives for patient outcomes could be a good thing if regulated in the correct way.
It had to be regulated.
Yeah, that's my stance on the whole thing. Yeah, no kickbacks or drugs.
That's the worst.
And no, no selection bias, and just kind of keeping the same things that a normal doctor would recommend and put into practice. Keep those in play. Just have the doctors be incentivized if they're actually successful with their outcomes.
Success is the one. Like the incentive should be the healthy patient.
Yes. Yes. Yeah. What is your guys' stance? I'm assuming
My stance, I think after all of this, like I said in the beginning, I was like on a yes/no kind of thing where I was saying like if we did it with a healthy turnover, but I cannot foresee that happening within the next 10 years. So no.
Yeah.
The stance for me is no. Like there should be no kickbacks. It should be your wage or whatever it is that you're getting, because that is what you're there for. That is your job.
Interesting.
And I just want to reiterate the question: is it acceptable? It's not saying are they doing it on purpose or is it negligence. I just want to highlight that. That's what we've been over.
And that's why we're touching base here at the end. That's why I was like, no.
And so I want to agree with you guys and say it shouldn't be allowed. Like, especially with my grandpa, like because of negligence or maybe because of purpose incentive, he had to wait 2 extra months just to find out what he got.
And I'm sure he's not the only one, you know.
Yeah.
I'm sure it happens all over. I've had many family with cancer, and I could reach out and find out, and touch back.
Yeah.
We could touch base on this again with more research.
Yeah.
Yeah, I don't know if I actually necessarily agree with you guys, because you guys are saying hard no.
I think that's the declaration I'm coming to here at the end.
Okay, even if like future extensive.
We're talking right now.
Oh, right now? Just put into practice right now?
Like right now.
No, definitely years of I think.
Like I said, I can't foresee there being a major improvement in our health system within the next 10 years.
Okay.
Especially with ChatGPT students coming out.
Yeah. Yeah.
So,
also, okay, bear in mind those students usually can't get away with ChatGPT when it comes to actual clinical work.
But they're gonna be being put into those
Yeah.
things. Like I said, mine was like a brand new doctor, and who knows what she did getting there, you know.
Yeah.
So I would say right now, no. 25 years in the future, maybe.
Yeah.
But no. Now we just had a whole pandemic where we experienced a factual no, bad idea.
Yeah. And like I said, based on those studies I found 2 studies saying it really wasn't a great idea.
Yeah,
versus
based
one
on
saying-
history
Yeah.
and present time.
Yeah.
No.
Like I said, extend more research. We need to examine the results more thoroughly. We need this to be in a vacuum where a research team is on it and actually thoroughly studying these results. And I think other factors, variables, medical protocols, but other variables need to be included or excluded from the scenario, from different experiments, for us to come to an actual conclusion where we can see that it's fit.
Right, and especially us being college students with no real medical experience.
Yeah.
I think that's about the best I could say is no, based on the news and the reports I've seen and the little bit of research that I have done and my own personal experience. I can't imagine it being a good thing right now.
Yeah, maybe when I'm a dentist, my mind will change. Maybe I'll actually say
maybe
no.
you'll be a greedy corporate son of a bitch.
Well, I don't. I'm saying maybe I'll say a hard no, because like I said, I can't see any world where I put money over health.
Yeah.
So
I'm just playing.
And if I become a pharmacist, like I'm not gonna be an incentive. Like Walgreens has a way that if patients think that I'm going to the pharmacy, I'm gonna have to do an incentive, like they get incentivized for it. We have a thing called Save a Trip where we reduce the amount of times they show up to the pharmacy. We get all the medications at one time and it agrees with the doctor, it agrees with the insurance, and that way if they do think it's the pharmacy, like we're reducing that. And if I get a PhD in medicinal chemistry and I become making drugs, like I won't be incentivized to do it, just to stop making drugs because I don't get paid enough. Like I would get paid more than I do right now and I'd be happy. Like it's not about the money, it's about what I'm doing. Like I enjoy helping people.
Right. I'm not going to be a medical professional. I'm going to be a research scientist. So this is about as good as my opinion's gonna get.
So, kind of the final stance on everything is all of us hard no.
Hard no.
Hard no now, right?
Hard no now. In the beginning, we had differing opinions,
But we all came
Came to
to,
a consensus.
kind of just met up with each
and
other
that
at
is
crossroads.
debate.
Yeah. So I think that's a wraps there.
Yeah, we got about 10 minutes before we gotta get out of
Yeah.
here. So yeah, that's
Thank you,
wrap it up.
Keenan. I hope you spent
100%.
Yeah. I hope you watch this entire thing, and I hope you don't see